First of all, thank you very much, our respected moderators, and assalamu alaikum, all audience and moderators. So in next 20 or 30 minutes, inshallah, we will discuss about the acute stroke management and what are the different treatments in the hyperacute and acute stroke. We will also discuss briefly about the mobile stroke unit. So why it is important to discuss about the stroke and why it is important that stroke needs the acute management. Because, in a stroke, we don't have any pain. But in heart attack, we have pain. That's why people, they go or rush to the hospital with the heart attack. But few decades ago, people, they don't have any pain. And there was no acute treatment for the stroke. So usually people, they were not going to the hospital and just they were staying at home. Then later on, we realized that every second, our brain neurons die. And if we can save those neurons, we can reverse the stroke in most of the time. So you can see here that up to 1.9 million neurons die in every minute. And almost 120 million neurons die in 1 hour. That's why it is very important to treat the stroke as soon as possible. So before going to the next slide, I just wanted to tell you that what is stroke? Stroke means that there is an occlusion of the blood vessels or rupture of the blood vessels. The brain will not receive any blood circulation. We divide the stroke in two parts, ischemic stroke or hemorrhagic stroke. Most of the stroke, 70% almost, are ischemic stroke. So we will discuss here about the management of the ischemic stroke. Ischemic stroke also we can divide, for example, according to the pathology, like a small vessel disease, large vessel, cardioembolic, or some undetermined etiology, or we can classify according to the blood supply, like anterior cerebral artery, ACA territory stroke, MCA, PCA stroke, cortical or subcortical. That's why we do the admit the patient to know that what type of stroke they have, so we can decide about the long-term treatment. So how our strokes chain survives? For example, if anybody who has any weakness at home or anything, they will immediately call the EMS service. EMS service will be activated, take the patient, go to the hospital. Our triage nurse, they will assess the patient. Then they will call the emergency physician. Emergency physician, they will assess again. They will call the neurologist, and then we will go for the further management. So you can see in this slide that how it is working, that within 60 minutes, we try our best to give the IV thrombolysis to the patient to save the brain. This is our target. But now in developed countries, they are giving within 30 minutes. So we try our best to reduce this time to save the brain. So you can see here that how it is, that fast, simple mnemonic to know that it is a stroke, then emergency triaging, and of course there is a ABC initial management of the stroke. But one thing, remember that what is the difference between a stroke and other things? A stroke patient, they don't have pain. And this is how we diagnose a stroke. If they have pain in the limbs or somewhere, then this is less likely this is a stroke. Except some exceptions are there, like thalamic stroke or something. Okay, so initially when the patient comes in the emergency, we do this ABC, initial steps. And vitals, of course, they will assess the vitals. They will check the blood pressure, pulse, everything, because there are some exclusion and inclusion criteria. They insert at least 2 cannulas before giving the TPA. They will take the proper history, first by the emergency physician and then followed by the neurologist. So what are the important questions in the history we need to ask? We need to ask most important thing, that when the last seen normal. For example, if the patient slept at 10 o'clock in the night and woke up at 6 o'clock, so we calculate from the 10 o'clock from the night. So this is very important because our window period is up to 4.5 hours. And how the symptoms was started, because in stroke, for the residents and students, the most important thing is onset, whether it is sudden onset or not. If it is sudden in onset, then most likely this is a stroke. So these two questions are very important. And of course, we will ask about the allergies of any contrast or dye, because we are going to do CT contrast. We will take the history of medications, whether patient is on any anticoagulations or not, anti-epileptics and these medications. Then, of course, about the risk factors and other medications. Last oral intake, because after TPA and these things, we need to keep patient NPO. And then we will ask about any prior history of the stroke to exclude, because of there are some exclusion criteria, recent MI, trauma, surgery, and bleedings. Because if anybody who has a recent bleeding or recent stroke, these are the contraindications. Along with this simple question, we have some other, that when did the symptoms begin, whether the patient within the window period or not, any history of recent trauma, any previous history of the stroke, any history of diabetes, any history of neck pain or any trauma or any other headache. Headache, actually, it is very important for the dissection or these type of the head strokes. So at the same time, as a neurologist, we need to be very careful, because sometimes we misdiagnose the stroke in the emergency, and these patients receive wrong TPA. But in one study, it showed that almost, even in developed countries, 12% patients who received the TPA, they were not a stroke. So sometimes due to rush of the treatment, we do give the TPA in the stroke mimickers also. So as an emergency physician or other physician, it is very important to know that what are the mimics. So the most common mimics is seizure. Seizure, we all know that how it presents. There will be aura. In a stroke, usually there is no aura. Seizure, there will be some jerky movements, upward rolling of the eyes, blue coloration of the face. There will be tongue bite, frothing, post-ictal confusion. But most important thing and most interesting, that in brainstem stroke, patient comes comatose and they present with seizure-like episode. For example, decortication and decerebration. So these things, most of the time, it is missed by the emergency physician or some physician. They think this is a seizure, but actually that is a stroke. So if you have any doubt, don't try to do the CT scan and CT angiogram to rule out any basilar stroke or any other thing. Seizure basically is not contraindication for IV thrombolysis, but as a clinician, this is a clinician decision that this is not seizure and this is a stroke. Then subdural hemorrhage. If somebody has a trauma, subdural hemorrhage, they will have the weakness. So of course, CT scan will rule out any metabolic or septic encephalopathy. So in the history, easily you can exclude this because they will have gradual in onset symptoms. MS patient also have more than 24 hours gradual onset symptoms. Migraine, this is very interesting, as Dr. Yasmin and Dr. Nof mentioned, that hemiplegic migraine. They present with hemiplegia, but in this type of the patient, history is again very important. They will tell you that their weakness is coming like a march-like fashion, slowly coming from the fingers up to the head. So again, this is gradual in onset. And this weakness will be followed by the headache. So that is again very important, how to rule out migraine from the stroke. Encephalitis. Patient will have unresponsiveness, drowsiness, and these things. So that is gradual in onset. You can easily ask about the fever or these things. Brain tumors, again, gradual in onset. Hypoglycemia, that is very important. So you need to take the history of sugar and immediately check the sugar. But in our setup where we are working in Rashid Hospital, I personally see a lot of functional patient also. So never diagnose patient as a function before excluding these things. But there are some techniques in the examination like Hoover sign, or from the history you take the risk factors and these things. So easily we can exclude the functional patient also. But even though 12% patients, they receive TPA. So after taking all this history and initial blood labs, and you insert the cannula, patient came within the 4.5 hours. So immediately patient will be rushed into the CT scan. So at the same time, we need to do the both non-contrast CT and CT angio. Why both? Because CT will exclude the hemorrhage and CT angio will tell us whether the size of the clot. Because if the size of the clot is big, then we need to go for mechanical thrombectomy. So if some patient, for example, if one patient comes within, for example, 2 hours from the onset, it doesn't mean that we have to wait for 4.5 hours. Even in that situation also we need to rush because time is brain. So after the CT scan, stroke team alerted, they call immediately. Stroke team always stay in the hospital most of the time. They rush to the emergency, they take their history again just to confirm that is there any stroke mimics or what's the last in normal. Initial blood labs we sent like ECG, chest x-ray, glucose, everything. And if the patient is on warfarin, of course, PT-INR is very important. Platelet count is very important just to rule out any contraindication for the IV thrombolysis. So after this all examination, we decide about the IV thrombolysis. So up to here in summary, that patient, if anybody who has the weakness, then they should rush to the hospital and we decide about the TPA if the patient comes within the window period, which is now 4.5 hours. So we calculate the NIHSS score. Before 5 years earlier, this was the part of the inclusion and exclusion criteria that above 25 NIHSS, we were not considering giving TPA, but now NIHSS is no more the criteria. For example, if somebody who has NIHSS 1 and he is a professor, he gives lecture, he has slurred speech, but that is his disability. It doesn't mean that we will not give him TPA because this is his disability. So even we will give TPA on NIHSS 1 or 2. Before, after 3 we were giving. But one old lady living in a hilly area and her NIHSS is 6. So again, risk versus benefit, probably we will not give TPA to that lady if family they don't permit. So that's why NIHSS is no more the criteria for giving TPA. So these are the list of NIHSS. So we do check NIHSS very fast. We don't delay the treatment, just go through this all within 1 minute or so on. So what is thrombolysis? Sorry. So what is thrombolysis? Thrombolysis means to break down the clot. And how do we know that there is a clot? If CT scan is normal, means there is no hemorrhage, and patient has a clinical weakness, and that is acute in onset or sudden in onset, then most likely this is clot. And secondly, in the CT angio, if the patient has a large clot, that will appear in the CT angio. So in that case, we first decide about the IV thrombolysis. So IV thrombolysis, we will discuss in the next slide that what are the IV thrombolysis. So our target by giving the TPA is to reduce the size of the penumbra to save the penumbra. Our target is not to treat the infarcted area, because when the patient comes with the stroke, there are 3 areas. One is normal area, then comes the penumbra where there is a hypoperfusion, and at the end there is an infarcted area. We don't treat the infarcted area because that is already gone. So we treat the penumbra system and to reperfuse the blood circulation. Okay, so for this all, what are the important key? Door to ED physician, we need to rush for the door to ED physician time. This is how we can improve our stroke management. Door to CT time, rush from emergency triage to the CT, immediately do the CT time. Yani CT time should be shortened. Door to neurologist time and door to needle time. So all over the world, we are working on this, how to cut this time to improve the our TPA time. Excuse me.
Dr. Kamran, there is 2 more minutes. Are you okay with it?
Yeah, sorry. Okay, so in our hospital, annually we have almost 800 to 1,000 stroke patients. Intervention is almost, we are doing 10 to 15%, TPA almost 1 to 120. Mechanical, we are doing 40 to 50. Our average door to needle time is, in last 6 months was 53 minutes, which is almost near to the international standard, because internationally up to 45 minutes. So we discussed that TPA should be given within 4.5 hours. This slide you can see here that this one is infarcted, this pink area. Another area is the penumbra. So we save the penumbra, which is a hypoperfused area. You can see here that after 6 hours, infarcted area has increased in the size. Okay, so if you will not treat, the infarcted area is increased. You can see here in the CT scan that after 24 hours, the hypodensity here, you can see the size has increased in the down slides. Okay, so exclusion criteria, inclusion criteria we have already discussed because we have less time. So if the patient has a high INR, so that patients are excluded. High blood pressure, 185 by 100 excluded, or we treat those hypertension with the labetalol. Low glucose and high glucose are also we treat first. Okay, so this one we have already discussed, seizure and these things. So these are the list of the trials since 1995 up to 2008. There are list of trials from ECAS 1 to ECAS 3, and all prove that LT plays have the role. So this is the journey, and the last now trial came in 2022, ACT trial, which showed that tenacity plays are also equally benefit with the LT plays, but also more than beneficial as compared to the LT plays. Tenacity plays, which is a single shot, because LT plays, which we give in our hospital, we have to give through the infusion over 1 hour. Tenacity plays 0.25 mg per kg, direct you can give. Okay, so just a minute. Okay, so there are last slide only. There were some bugging question. Actually, I wanted to discuss those questions. If you can give me another 2 minutes, that is very interesting for our doctors. Just allow me for this thing. When to start the anticoagulation in the patient who have already stroke. So usually we check the size of the stroke, and it depends on the 0, 1, 7, and 14. If it is very TIA, the next day, if it is small, less than 1 centimeter, 3 days, less than 1/3 of the territory, 7 days, if it is more than 2 weeks. Okay, but now the many papers are coming, and according to them, safely we can start within 5 days according to the size of a stroke. DOACs versus vitamin K agonist. DOACs in all non-valvular heart disease. Vitamin K we prefer to give in rheumatic heart disease or valvular heart disease. Okay, dual versus single antiplatelet. We give single antiplatelet, but TIA and the minor stroke is preferably according to the ISIS trial, dual antiplatelets. DVT prophylaxis in stroke, yes, you can give the enoxaparin 40 milligram. Then antithrombotic and hemorrhage. Suppose the patient is on aspirin and they have the hemorrhagic transformation. So you just repeat the CT. If there is no worsening of the hemorrhage in the hemorrhagic transfusion, you can give if it is indicated. But if the patient is on anticoagulation, there is a hemorrhage, you need to stop, wait. Once the hemorrhage subsides, then you resume the anticoagulation. Then IVT and MT with anticoagulation. Patient is on warfarin, so whether you can give thrombolysis treatment or not, you will check the INR. If it is 1.7 or less, yes. Patient is on DOACs, you have to wait for 2 days or extensive workup, then only you can give. Patient mechanical thrombectomy, yes, they can go for mechanical if the patient is on anticoagulation. There is no contraindication. Recurrent stroke with antithrombotic. This is the last thing which I want to tell, because so many referrals come for this. So if the patient has a recurrent stroke, even patient is on 2 antithrombotic on this, you should continue the same. You should control his risk factors, sugar, blood pressure, these things, and you need to find out the other etiology of the stroke, whether it is cardioembolic or not. Similarly, if the patient is on anticoagulation, and again he has the stroke, then again you need to find out other etiology. You can check the DOACs with the warfarin, or you can check, for example, apixaban or rivaroxaban. Paper showed that dabigatran is the more efficacy as compared to those, so you can change with the dabigatran. Okay, thank you very much.